Good afternoon. On behalf of the UNC Health Foundation, I want to welcome you to this afternoon's discussion on health equity, and specifically how the UNC Lineberger Comprehensive Cancer Center is working to investigate and eradicate cancer health disparities. My name is Martin Baucom, and I'm Vice President of Development for the Foundation, which secures private funding to support research, patient care, and medical education at UNC Health and the School of Medicine. I'll be your host for today's event. The Foundation has, for the last couple of years, organized a series of events focused on the impact of the research and care that our fundraising supports. And so we also, in these sessions, try to highlight the ways that philanthropy has forged that impact. UNC Health and the School of Medicine are fundamentally committed to health equity for all. So we wanted to dedicate some of these events to this important set of issues and the work that's being done in this area. Today, we're really excited that you've joined us to hear from leaders who are contributing to an environment of diversity and inclusion and heading the charge to eradicate health disparities in North Carolina and beyond. So we'll focus today on, as I said, cancer health disparities, how UNC Lineberger has taken action through patient and clinical care, accrual to clinical trials, recruitment and retention, education and training, culture and climate, and enhancing research with an equity lens. Because we also want to emphasize the opportunities for philanthropy, I would like to mention one project in particular that's being advanced by a recent wonderful gift. And it's basically, Lineberger has, I think, for more than 2 decades, investigated racial disparities in breast cancer outcomes throughout North Carolina. And that's through a program called the Carolina Breast Cancer Study. The work has highlighted a staggering 40% mortality gap between Black women and white women diagnosed with breast cancer. And the gap exists because of a mix of issues related to access to care and to biology. In order to move the study forward into its next phase and to implement steps that will reduce that 40% gap and save lives, Marilyn Jacobs Pryor and her husband, Rich Pryor, have recently stepped forward to commit $1 million to this project. So a truly wonderful, wonderful gift and a great example of how philanthropy can directly address health equity and reduce disparities in care. So now I'd like to go ahead and introduce our 2 terrific speakers for today. I'll go through their introductions and then ask them to share some personal reflections before we get into the meat of the program. So first up, Dr. Wendy Brewster, who is the co-chair of Lineberger's Equity Council. She's also director of the UNC Center for Women's Health Research and a professor in the Department of Obstetrics and Gynecology. Dr. Brewster is a practicing gynecological oncologist, and her research identifies and evaluates populations at risk for disparate treatment and poor outcomes in endometrial, colon, ovarian, and cervical cancers. In all that spare time she has, Dr. Brewster enjoys traveling internationally and attending the theater. We will also hear from Dr. Stephanie Wheeler. She's a member of the Equity Council for UNC Lineberger and is the Associate Director of Community Outreach and Engagement for Lineberger, as well as a professor of health policy and management with the Gillings School of Global Public Health. Dr. Wheeler's research focuses on understanding cancer care quality, access, equity, and value for medically underserved groups. She has led studies focused on comparative and cost effectiveness of breast cancer care, patient preferences, and values in medical decision-making. That includes using big data and analytics to better understand complex healthcare issues. In her spare time, Stephanie has shepherded 4 children under the age of 7 through a global pandemic. So I don't know what else is left.
What spare time?
Exactly. So to start with, Dr. Brewster and Dr. Wheeler, could you both share some personal reflections? What's it been like to work on the issues that you so passionately address and that you're going to talk to us about today in the midst of this global pandemic for the last 15 months or so? Dr. Brewster, if you can start, and then Stephanie, and then from there, we'll move into your presentation on cancer disparities.
Well, what I'll say is that I admired our healthcare system admirably for how we responded. And this is with the caveat that when things got really pressed here in North Carolina, we had the advantage of learning from what happened in Italy, what happened in New York and other big cities. And just the way my colleagues, when I say my colleagues, I mean, everyone within the healthcare space adapted quickly. Things change from day to day, and it was wonderful to see that changing. And we were doing this all to be sure that our patients could have the best healthcare outcomes. Reflecting back on some of the things that have been made better, it's patient access. We learned just like that. I tell you, over years and years and years, there was all this talk about how we do virtual visits, and it happened within 2 months. And I hope it's here to stay, because I think that's really a tool that will help deliver care, especially since we provide care here to the far reaches in the state. And that's an opportunity for those patients to interact with the care, with the specialty care, that if they need it here in an easier way. I'll almost finish. I learned to appreciate my family and friends even more. I got in touch with so many friends I hadn't gotten in touch in the real time, and that was an opportunity. And I miss my patients. A lot of my newer patients, I don't know what they look like till they go to the operating room and the mask comes off. I miss the hugs, and I'm looking forward to getting back to that. I miss getting to know their families, because that didn't happen. And so, yeah, that was a reflection on the last, how many months? 16 months?
15, 16.
Too many.
Yeah.
Oh, really well put. Thank you.
So Martin, as you shared, it's been a wild 16 months with 4 little kids at home. I've grown to appreciate the art of making Jell-O and muffins and art projects and digging for worms in the creek. And my son actually caught a crawfish in the creek behind our house. Who knew that we had those here? So a lot of time outdoors and a lot of time trying to support my family's learning needs. Although I educate college students and grad students, it's really different to try to educate a 7-year-old and a 5-year-old. I've learned. But the other thing I'll say, in addition to Wendy's really wonderful points, is that I think so many of the issues in terms of barriers to access to healthcare that we appreciated were there for many, many years as disparities researchers were brought into sharp focus by the pandemic. Issues with transportation, issues with not being able to get care in a timely manner, the limited broadband connectivity and cellular connectivity in rural areas made it very difficult for many patients to take advantage of the telehealth visits that Wendy was talking about. And so I think all of these things clearly took a disproportionate toll on Black and Brown communities and on rural communities in our state and elsewhere throughout the country. So I think it really has presented us with an opportunity to not only think about those COVID disparities, but also refocus our intentions on cancer disparities, which share many of the same underpinnings and the structural determinants.
And to just build one little thing, and I know that Stephanie and I agree on this, one of the things these last 16 months taught us is that research is important, right? We all got through this pandemic because of research and doing research well and pivoting and doing things efficiently and thinking about the needs of the patients. And so that underscores all the work that's done in the work that's done in the clinical space to advance health.
Great point. Well, that all is a wonderful lead in and introduction to the presentation that you're both going to share with us. And I think Dr. Wheeler, you're up first. So.
Okay, so hopefully I'm sharing my screen. Martin, tell me if you can't see it.
You can see it. And if I can make one reminder, I know that this presentation is going to spark questions. I hope that it does. Please put those questions that you have in the Q&A function, and I will be fielding with some help, and we'll make sure that they're addressed by Drs. Brewster and Wheeler. Thank you.
All right, sounds good. So I'm going to kick us off and talk about some of the trends that we're seeing in terms of cancer health disparities in the state and some of the research that has been catalyzed as a result of what we've been looking at. So in terms of a roadmap, I'll start with describing our community outreach and engagement efforts at UNC Lineberger, and then turn it over to my good friend, Dr. Brewster, who will share our work with the Lineberger Equity Council. And then at the end, I think, Martin, we're going to have a little bit of a discussion about some potential actionable opportunities for folks. So in terms of the Office of Community Outreach and Engagement here at Lineberger, this is an office that was established almost 2 years ago now. And it's really a formalization of a lot of efforts, as well as a commitment by Lineberger to continue to lead and to be more focused and deliberate as we catalyze new research in high need areas. So as the state's cancer hospital, we are leveraging longstanding as well as new partnerships across the institution, across North Carolina and the globe to achieve these aims. So first, we monitor cancer burden and identify disparities in North Carolina. Second, we're focused on synergizing diverse community engaged efforts to address the cancer burden and specifically disparities. Third, focused on efforts to amplify and extend cancer outreach and supportive care. And then finally, to facilitate more impactful and equity-focused research, which you'll get some examples of in just a few minutes. So we've been doing this for a very long time at UNC, dating back to the foundational work of folks like Dean Barbara Reimer, Laura Lenan, Alice Ammerman, who's the director of the Center for Health Promotion and Disease Prevention, Marcy Campbell and Paul Godley, of course, who are no longer with us, unfortunately, and Joanne Erb. And so the establishment of this office a couple of years ago really just kind of pulls many of these efforts together and allows us to think about consolidation of community outreach and opportunities for us to do even more together. So this is the structure of our office. Of course, we report up to Dr. Erb, the director of the center, and we have a triad leadership structure consisting of myself, Dr. Marjorie Charlot, who's a thoracic oncologist in the School of Medicine, and Barbara Alvarez-Martin. And we're accompanied by just a wonderful team of folks who have really specialized expertise in community health education, statistics, outreach coordination, telehealth, you name it, we've got that expertise represented in our office. And to get into some of the data, I think it's really important to note that our cancer and outreach efforts here at Lineberger span the entire state. All 100 counties are represented, and we provide cancer care to patients from all 100 counties. 91% of our cancer patients are seen here in the central region of the state. And then just as a reminder of who our catchment area population is, North Carolina is about 30% minority race with 10% of people who are Latinx, 23% reside in a rural area, and 16% of North Carolinians live below the poverty line. Zooming in just a little bit on that rural experience, so about a quarter of North Carolinians live in one of our 54 rural counties. And this is really important because, as I said earlier, rural North Carolina faces greater challenges than non-rural communities in terms of higher poverty, lower education, lack of access to broadband connectivity, and of course, lower access to healthcare services. So this is one of the populations that we focus on, in addition to our racial and ethnic minority populations in the state. So we use a Lineberger resource called CIPHER, which is the Cancer Information Population Health Resource, to monitor cancer trends. And so reflected here are data showing differential mortality disparity by race, by ethnicity, and by rurality. And as you can see, there are many cancers in North Carolina where these populations shoulder a disproportionate burden. And we've prioritized research in the past 5 years on cancers like prostate, myeloma, endometrial, breast, cervix, colon, and lung cancers. And you're going to hear a little bit more about those in just a few minutes. In terms of behavioral risks, obesity is more prevalent in our state's Black and rural populations relative to white and non-rural populations. Lack of physical activity is more common among our Black, Hispanic, and rural populations. And smoking and heavy drinking are pretty similar across different groups. So our Office of Community Outreach and Engagement, after monitoring these cancer burden trends and really trying to understand the population's needs in terms of cancer health education as well as access, the key areas where we focus on are trying to provide technical assistance and evidence-based implementation support in communities to address these issues, to link researchers with the community, to disseminate evidence-based information and resources, facilitate access to cancer care, and really to fund and catalyze community engaged research teams. And one of the programs in which we do that is the Cancer Prevention and Control Research Network, which we have a screenshot of our annual meeting shown here. We are all enjoying Zoom with our funny facial expressions and costumes to make it a little more interesting. We've done some creative things with Zoom this year. But this is one of the ways where we catalyze community practice partnerships all across the country. And one of those 8 sites is located here at UNC. We also work very closely with the Clinical Protocol Office to develop efforts to ensure that the demographics of our clinical trial participants mirror that of our catchment area. And I think we've been quite successful in achieving that representation. So our trial accruals among African American and Latinx populations are higher than the proportion of those populations statewide. And as you can see, our rural interventional trial accruals also mirror that of the rural population in North Carolina. And some of the ways that we focus on representation in studies is embedding an African American trial navigator and a Spanish interpreter in our clinics. And Dr. Charlot is actually looking at ways to automate patient screening for clinical trial enrollment. So there's a lot of opportunity to support those kinds of efforts to ensure that representation in our studies is meaningful in terms of our state. So I'm going to turn now to a couple of efforts where we have conducted what I would call community responsive research. And one of the best examples is our Carolina Cancer Screening Initiative. So this was established several years ago under the leadership of Dr. Dan Royland, shown here on this slide. And Lineberger provided initial seed funding through which this group was able to engage 17 organizations across the state, they're all shown here, to enhance colorectal cancer screening initially among Spanish-speaking, Native American, and uninsured, publicly insured, and rural populations. And then this group, including myself, worked to write additional grants to extend these efforts and to test the ability of evidence-based programs like mailed fecal test outreach to specifically serve hard-to-reach populations, including rural communities. So over 11,000 FIT kits have been mailed through this program. And one of the things that has happened more recently is the Carolina Cancer Screening Initiative has expanded to include breast cancer, lung cancer, as well as cervical cancer screening efforts. A second example is the work that has been done through the Greensboro Health Disparities Collaborative under the leadership of Dr. Sam Seichert and Jeannie Eng. So they developed the ACCURE study several years ago with this group, the Greensboro Health Disparities Collaborative, that identified an initial disparity in receipt of appropriate treatment for lung and breast cancer. And they worked together to develop a program that essentially it was a multi-component program that could identify and target patients for treatment receipt in a more timely manner. And over time, this resulted in the complete elimination of racial disparities in lung and breast cancer treatment among these participants. Now this program has been implemented as standard of care in the Cone Health System, and Dr. Charlot and others are working to embed it in the North Carolina Cancer Hospital. This collaborative also has been really instrumental in assisting with charrettes, which are community engaged listening and problem solving sessions with folks like Dr. Cleo Samuel. A third example is work that has happened through the North Carolina Cancer Survivorship Professional Action Network and the CCSP, or the Comprehensive Support Program, led by Dr. Rosenstein. So this program has been around since 10 years ago, I suppose. And one of the things that they have done is extend the Cancer Transition Survivorship Support Program throughout the state, as you can see on this map here, and translated that material into Spanish. And you can see the numbers of patients that have been reached through this program. Using this network, Dr. Mayer has worked through a Duke Endowment grant to also provide lay navigation to centers and patients all throughout the state. And then we have worked with this network to develop and implement a financial navigation program as well, which was characterized by the community as the #1 unmet need in their area. And then lastly, I want to draw your attention to some of the work that the Carolina Breast Cancer Study has produced. So Martin shared that this has been one of the success stories of Lineberger, and just 2 of the studies that have come out of this amazing resource and this amazing cohort have shown 2 important findings, which I just want to highlight here. First, that Black women experience greater financial distress than do white women after breast cancer treatment. And this financial distress is multimodal in nature and ranges from experiencing transportation barriers to care to losing their jobs, as well as losing insurance after breast cancer diagnosis. And secondly, that Black women have higher symptom burden, lower treatment adherence, and higher discontinuation of endocrine therapy after prescribed it. And this data here demonstrates the high rates and the severity of symptoms experienced by Black and white women who are taking tamoxifen or aromatase inhibitors, and really motivated us to think about interventions to support women during this aspect of their care. And so with those last two examples kind of teed up, I want to share two scale-up studies that are happening right now that draw directly from those early lessons that we learned from Carolina Breast Cancer Study. So first, Don Rosenstein and I have an R01 grant from the National Cancer Institute that is utilizing financial navigation to directly help patients who are struggling with the financial burden that their cancer care is causing them. We initially pilot tested this program here at Lineberger at the UNC Cancer Hospital, and it was highly successful in improving financial distress scores in an initial cohort. And it had excellent patient satisfaction and high fidelity. And this model used social workers to do comprehensive intakes and really think about screening patients actively for financial distress during their treatment. And then we basically worked very closely with them to identify their eligibility for potential resources that can support them, both medical and non-medical in nature, and then work with those patients closely, as well as their caregivers, to direct them to those resources and to help them complete applications and check in with them regularly. This program now is being implemented in 9 different sites across the state, utilizing that C-SPAN network that I mentioned earlier. 5 of those sites are rural and 4 are non-rural. We expect to have about 700 patients enrolled by the end of the study. And then finally, drawing upon the results we learned about endocrine therapy adherence and the multifactorial reasons why women experience trouble with this medication, we worked to develop and implement a pilot study here at UNC, as well as our REX satellite sites, to provide motivational interviewing counseling, which is a very patient-centered intervention, to support these women in overcoming their barriers to medication adherence. And this was all culturally adapted. We worked very closely with patients and caregivers in working through it, and then received Dr. Reeder Hayes and I, who's a medical oncologist here, an NCI-funded R01 grant to scale this up in the Alliance Network. And we will have about 1,200 women who receive either just motivational interviewing counseling and or text message reminders as part of that program. And there's a number of other components that are involved in that. And to conclude, I'm just going to try to share a video clip from this Get Set study to show you a little bit of why this particular program is helpful for women undergoing this treatment. And Martin, we're going to see if this works, so you'll have to give me a thumbs up if the sound is working.
My why is my 7-year-old daughter. That is the life of my life. She is the blessing from God. I am privileged to be her mother. And we have a lot to do together. I have a lot that I want to teach her, a lot that I want to show her. The other part of my why is my mother. Now that I am a mother, I can't imagine the pain of being alive and my child not being with me. I realize that taking a pill a day is not that big of a deal. I have some perspective in terms of what is hard. And so this for me is important for myself, for my daughter, for my mother, for my community. And to put me as an important part, there's a lot of things that I want to do with my life. There's a lot of living that I have not done yet, a lot of experiences that I feel like I deserve, and a lot that I have to give to my community, to the world. And so those are all things that contribute to me making time to take care of myself. Even though my estrogen levels were lower than before, I am still beautiful, and I am still a woman, and I am still alive.
That makes me tear up every time. That's
Mm.
Naisha Frey. She was our motivational interviewing counselor, and she also is a breast cancer survivor. So with thanks to Naisha. And Wendy, I'll turn it over to you.
Great. Would you mind advancing the slides for me?
My wise, my 7-year-old daughter,
Sorry.
that is the life of my life. She
I mean, it's great. We'll listen to it again, but
Here you go.
yeah. So this part, I'm gonna spend some time speaking about the UNC Lineberger Equity Council, and this is an equity council that got formed last year. Just July 2020 was when we actually decided this was going to happen, and this in large part was spearheaded by Dr. Wheeler and others in the well-established community outreach and engagement community. Because you can see from the work that she's just described, it would just absolutely make sense that this was a priority. And so the American Cancer Society, I believe the motto or whatever that word is they use for the, how they tag the year was something like equal health care for everyone, everywhere, every day. Maybe not in that order, but that sentiment. And that's a sentiment that we wholeheartedly believe here at UNC Lineberger. It's great working here because there is a responsibility that everyone in the space, researchers, people on the healthcare clinical team, or others who support this endeavor know that we want our state to have the best health. And to do that really means paying attention to how we bring equity, inclusion, and diversity and those principles into Lineberger. And so there's 6 areas that have been prioritized. And the goal is, so, we all know that you can't make a difference unless you're measuring what that difference is. And so the Lineberger Equity Council has been charged with defining measurables and identifying a plan where we implement these changes. And these 6 areas are patient and clinical care. And when we say patient and clinical care, but we also mean making sure that the experience too for the families and for the people who love our patients and who provide support for them, so that everyone can get the best outcome. We have to believe intrinsically that everyone wants to be cured of their cancer, and we have to believe that no one wants to get cancer. And so how do we address that and measure that to be sure that everyone's having the same outcome? Dr. Wheeler mentioned a lot about clinical trials, and I think I stated at the beginning is that meaningful progress comes when we have data in which we can look at, we can pivot, and we can determine what is the best way to provide care. And it's important that we know what's the best way to provide care for all of us. Some of you might remember back in the 1990s, there was this cardiovascular health study that was done, and it was largely white men. And we had to learn the hard way that the findings of those studies did not apply in the same way to women. And so for that, we need to be mindful that when we do clinical trials, the results of our clinical trials will provide information that gives better health for us all. Recruitment and retention is another important area, and this is a fantastic place. And we need to be sure that we have enough people at the table who are looking at this from a different perspective, and we have to be sure that when people are here, everyone's meeting their full potential. If we all can't meet our full potential or work at our full potential, it's hard to argue that we're not losing, we're not missing out on a lot. The same is for education, training, and onboarding. One of the things about being on the Lineberger Equity Council, they're difficult conversations. And since the events of last May with George Floyd, there have been difficult conversations, I know, in multiple different quarters. And part of our challenge is, part of our goals are to be able to communicate better with each other, express what we're trying to say in more constructive ways, so that we can all thrive and grow and stay here and contribute the most that we can to UNC Lineberger and UNC overall. But this isn't done unless we are sure that we're in the right culture and climate. And I know that you're all aware of the saying, climate and culture eat strategy for breakfast every day. And so we're very mindful that this in very many aspects will require a change in how we view ourselves and what our culture is. And UNC Lineberger is all about research, making a difference that's meaningful. And that very often it is with research in the basic science labs. You know, we have to be sure that all the mice or all the tests that we're doing aren't on the same type of person's tumor, or else we'll have results that don't necessarily help us all. Next slide, please. And this is Lineberger Equity Council. I am just absolutely honored to be able to work with these colleagues of mine. And I'll share with you a little bit later what we have done just since last year, October, when as a group, phase 1 began. So this has been divided into 2 sections. The first one was actually evaluating the landscape, which is phase 1, and identifying what are the things that needed to change. Because we all agree that there's some things that need to be changed, but there's some things that aren't going to change for 5 years. But we have to start working on that now in order to have something meaningful happen down the line. And then there's some things that should just never have been happening, and we need to change those now and pivot quickly. And those are what we call quick start. So we have a group of about 32 people, and over the last 8 months, developed recommendations and quick start action items. And we had our last meeting of phase 1 last week, Friday. And we are now moving into phase 2, and that will begin in September, where it's more about implementation and accountability. It's been exciting. It's been hard work, but hard work is hard. And what motivates us all is at the end of the day, the goal is to make the health better for our patients at Lineberger, our patients in the state that we serve, and to be sure that we can all maximally contribute at work. Next slide. And so these are some of the goals, not all of the goals, you know, because it was a lot of material, but I thought it would just be, important to share with you what we're doing so you have a sense of where the areas we're working on. So for example, education, training, and onboarding, we need to have a clear path. When people join us at Lineberger, we all need to be joining with the same understanding of what our goals are and what are processes for advancement, what are opportunities, so that everybody has the opportunity, if they so wish, to make contributions. Culture and climate, it's very important, and we're working on a daily basis to make this a more diverse, inclusive, and equitable environment. Patient care and patient and clinical care, that's the reason we're here. And we have, as Dr. Wheeler has discussed, we need to have resources and time to eliminate the health disparities, and we need to be able to provide our patients with opportunity for equitable, optimal, culturally sensitive care. We all want a life that maximizes our duration at the time we're here and our quality of life. And with patient and clinical care, go enhancing research with an equity lens and accrual to clinical trials. And I've discussed that before. And workforce diversity, recruitment, and retention. We want to recruit, develop, and retain all the absolutely wonderful people we have here, so we can provide, and in that spirit, people need to have the opportunity to have equitable employment and opportunities, or they will go somewhere else where those needs will be met. We have a very good pipeline here, and we need to work on making sure that there's not a lot of leakage in our pipeline. And so the people who are here will stay here, contribute to here. And so all of the mentorship and sponsorship and time can be reinvested here. Next slide. And so this is our framework. It's serious business. You know, we've identified the problem, identified measures, proposing solutions, and that's what will happen. That's what happened over the course of the last few months. And we're at the point now where we're developing an action plan. At the meeting last week, we prioritized solutions. We ended up with, I shared with you about six items, but they were more than that. There were actually 24. And what do you do with 24? You know, they're resources, they're human resource, there's time resource, and then there's the cost of having all of that happen. And so it requires a prioritization exercise, and then creating realistic timelines for each and assigning responsibility. And that will be done over the course of the summer. And so when phase 2 starts, we can then get moving on addressing these 24 issues. Next slide. So we talked about phase 1, we spoke about phase 2, but this slide is more to share with you that we're being realistic about this. You know, across this country, there's been an awareness that things can't continue the way they are. And no one knows the exact way forward. And we are open and embracing the fact that we will study, we will act, we'll make our plans, we'll do, and then we may have to do something different. We're going to have to study what we did. We will have to tweak what we do. We're open to the fact that we don't know all the answers, but we are certainly in the space we're open to learning, and open and committed to learning from missteps that we will make, and open to the fact that things that we do well, we'll work on making those better. Next slide. And these are some of the items that occurred within the first 8 months. The most important, there were educational webinars that educated Lineberger across the board, right? Gave people the opportunity to be educated on race, class, and cancer. Dr. Wheeler talked about RFAs, and these are requests for applications. This was funding for people to do research, and because it was over the period of time of COVID, and we all know about the disproportionate impact of COVID on different areas in our society, there were funds dedicated to study that. We had a center-wide town hall event, and most important and very expensively, if that's a word, had Racial Equity Institute training. It's really difficult to have conversations if you're not sure how to speak. A lot of people are afraid of saying the wrong thing. I am afraid of saying the wrong thing, so I can only imagine how maybe others can feel. And this was a great opportunity to have those within the Equity Council have just basic building blocks, vocabulary, structure. This is where we're starting. And now, we talk about, is this a fish solution? Is this a lake solution? Is this a groundwater solution? Now we want to have solutions ultimately that are groundwater, meaning that they're intrinsic and they change everything. And we've also hosted training about NIH supplements. And we've had 12 listening sessions, and these were sessions where literally geared to different groups across Lineberg, junior faculty, senior faculty, leadership, the healthcare team, nursing, to hear what their perspective is, because you'll only fix things well if you really know what the challenges are. It's sort of like this huge elephant, and we just had to be sure that we were touching all aspects of the elephant to be able to do this work well. Next slide. And this is an example. Danny Fitzgerald Ellis, somebody who is on the Equity Council. He's not faculty at UNC. He is a patient advocate and leaned in. And on the Lineberger Equity Council, we are very fortunate to have members of our community, because how do we make patient care better unless we have a perspective on how the patients feel? How do we make accrual to clinical trials better unless we have a patient or family member or somebody supporting that patient tell us how we can do this better? And Dr. Ellis spoke to us about financial toxicity. This is a slide of a lecture he gave, but he also told us about what it was like from a patient experience receiving care at Lineberger. And from that, a lot of change will come. And so I'll briefly just talk about root causes for health disparities. And this is not something new. This might seem that it's new over the last year, but this has been something that's been talked about in medicine for over 15 years. And this comes because of systemic, provider, and patient factors. Next slide. And I thought I would just talk about, just leave this slide, I'm not going to read everything on it, but this shows GYN oncology and looking at determinants of health among women in North Carolina. And the determinants of health are multifactorial, right? It's your education. Do you have insurance? Do you have access to medication? Are you employed? Are you have access to a physician? And North Carolina rates number 42, and that's 42 out of 50, one being the best with respect to health insurance coverage. Next slide. Quickly, because Martin, can I take 2 minutes of your time? We're going to spotlight GYN oncology as an example. This is the most common gynecologic cancers, and it occurs generally among women at the age of 62. Next slide. But what's interesting here is that and I bring this up because the slide Dr. Wheeler showed indicated that there's a twofold difference in outcome. This is one of the most marked disparities, not only in our state, but across the country. And this is when you look at the different races. Caucasians, that's the yellow line, and that's where all races overall, but you can see how Black women just do much, much worse. Next slide. And so this is an opportunity for us to do better. We have to do better. It's just not acceptable. And so why are there these differences? That's where we will use what's been learned from the accrual trial that was done in lung cancer, that erased those disparities, to evaluate how we can change this by impacting access and managing diabetes, obesity, making sure that other medical factors don't limit the amount of chemotherapy or radiation or surgery that's done. The next slide. And this is an example. There's endometrial cancer research. The Carolina Endometrial Cancer Study is modeled very closely off the breast cancer study because of the success of that study. And this is a study where we're, over the course of the next few years, want to evaluate endometrial cancer, want to investigate who's getting what type of care where and why, and what we can do to make those changes so that we can at least as much as possible decrease the variation in symptoms and receipt of guideline concordant care. Next slide. And so this is where this opportunity for engagement. We labeled the slide how Lineberger includes all community. And when we speak about community, we mean about the people not affected. We talk about the people in our living environment, and the community includes work. Next slide.
I think, Wendy, this was the part where we were maybe going to turn it over to Martin. And then
it's Martin. We turn it over to Martin. Okay.
And then there's a couple of opportunities if Martin wants to go there next.
Okay. So can we advance the slide, or is there another slide after this one that highlights some of those opportunities? I believe
Sure. Yeah, we can go through those quickly. So Wendy,
we'll go through really quickly. So I spoke about the this is one. Communication is the biggest part of anything moving forward. Internal communication, external communication, and with communications come education. And so this is an opportunity. The next slide. I've spoken about the Carolina Endometrial Cancer Study. and we've learned what went well in the breast cancer study, and we want to duplicate this in endometrial cancer, because that's a disease that would benefit from being able to be as impactful as the Carolina breast study. Next slide.
And this is one of the many efforts that the Community Outreach and Engagement Office is championing, which is focused on engaging community and patient voices in all of our research. We have a number of different advocacy councils that folks can get involved with if they are a caregiver, a patient, a survivor, and a whole host of reasons why that is beneficial to both sides when patients and community members do that. Another effort that we have underway is supporting community pilot programs. And so this would provide funding directly to community organizations to work with us to identify a community cancer need and to develop a plan to implement evidence-based interventions or programs to address those needs. And so that will be getting underway in the next year. And we would love to have community input to that. And then finally, I described our work focused on financial navigation in 9 different oncology practices throughout the state. The model upon which that was built is right here in our backyard at the Comprehensive Cancer Support Program led by Dr. Rosenstein. And within that program, there is a patient assistance fund, which helps patients and caregivers with the non-medical direct costs of their cancer care, and that's managed by Cindy Rogers. And so there's a whole host of resources that are available online for folks to take a look at and to make contributions if they would like to support patients and caregivers undergoing care. And that's it. Martin, back to you.
Great. Yes, and Cindy does obviously a wonderful job with that program, and the fund has really empowered donors to provide incredible support over the years to offset what's really a terrible financial burden that cancer brings with it, and that has helped so many patients and families in North Carolina. So appreciate you highlighting that, Stephanie, and Dr. Brewster as well. Great presentation. We do have a few questions that I wanted to give you the opportunity to answer. First up is, how can we increase the diversity of our medical providers? Wendy, you touched on some of our efforts around recruitment and retention, within Lineberger and the School of Medicine. What other ways, what other things do we have in process to make sure that we're increasing, again, the diversity of care providers?
So we are at a distinct advantage when we look at, we have a nursing school here, we have a public health, the best public health program in the country. Our residencies across the board have diversity that is way more impressive than the diversity of the faculty. And we have an opportunity for those people who we're training here to stay here, or to maybe get the first part of their education somewhere else and come back here after they're trained. So that's an opportunity. And also, if everyone wants to succeed and thrive, and the culture here is good, and we are working on making it better, making sure that when people are here, there are opportunities. And building on that mass, I believe we more than have a critical mass, but it's when people are here, people will come here. If people feel that this is a place where they and their families can live and thrive, that's what they'll do, where there are opportunities for advancement. And it's not just doctors, right? It's researchers. You could argue that that's even more important.
And if I can maybe just add a little bit to Wendy's terrific answer, North Carolina has the largest proportion of HBCUs per capita than any other state. So we have a real opportunity to leverage the strengths of our HBCU community as well as we build that pipeline and try to really engage diverse folks in training. And with that comes a commitment to scholarship and to providing funding for scholars who may be, first generation. And I think that there is plenty of room for philanthropy to support that. We all know that the cost of higher education is a massive barrier to entry for many people.
Well put. And, I think institutionally, we pride ourselves on access from a fundraising point of view. I mean, we have a unique commitment to ensuring that all students can come to Carolina and get an education if they want. So it's an important part of what we do. Next question is, how has Lineberger specifically catalyzed research that focuses on equity and inclusion?
I'll have Dr. Wheeler speak to those incredible opportunities that have been formed even over the last year and what's been ongoing.
Yeah, maybe I'll start with that. So we have a developmental funding program through Lineberger that is open to researchers across the disciplinary continuum, from basic science to clinical and translational to population science. And through that developmental award program, leadership at Lineberger has been able to target specific types of awards to the researchers and the members of our community that focus on high priority areas. And in the past 2 years, actually beyond the past 2 years, we've had a number of targeted funding opportunities specifically focused on cancer disparities writ large, and then also focused on cancer disparities just here in North Carolina. We've also had community-focused targeted funding opportunities available where we actively encourage our researcher community to partner with community organizations. And so that really requires researchers to get outside the box of, the academic ivory tower and start to talk with community members and start to formulate those partnerships, whether it be with churches, with YMCA programs, with barbershops, beauty shops. I mean, we have a very rich history at Lineberger of doing that kind of work. And I think with some of this funding, there have been numerous successful pilot programs that have been enabled with that kind of funding that can then go on to larger scalable, foundation or NIH support to make those types of programs more accessible. So funding is one. Oh, sorry, Wendy, go ahead.
Yeah, Stephanie, don't forget to talk about the supplement, the NIH supplemental training program.
Yes. So there's been a number of opportunities that have come directly through NCI. One of them is the Geographic Management of Cancer Health Disparities Program, or GMAP. This is a regional network that is focused on developing cancer health disparities researchers with a focus on developing investigators that are underrepresented in the biomedical sciences. And so that program has been here for a number of years. We partner with Vanderbilt, the Medical University of South Carolina, as well as Wake Forest and Duke and our HBCU partners to really try to attract diverse scholars to the field and to get them invested and trained up to do cancer health disparities research. So those are just two, and maybe I'll stop there given the time. How about that?
Sounds good. What an impressive array of activity that's ongoing under the heading of diversity here and health equity across the Cancer Center. I so appreciate the two of you taking your time to walk us through all of that. I certainly learned a lot today. I'm sure everybody who was here did. So thank you very much again for your time. For the energy that you bring to presenting these materials, and certainly all the tremendous equity, and effort that you put into building these programs over the years. So we all appreciate it very much. If I could ask for the slides to come back up, and I'll share a few more items with you. Here we go. Excellent. Okay, so just wanted to provide a couple of UNC Health resources for you. First up, this is how you can learn more about our own health equity funding program. We have a fund that supports health equity initiatives across UNC Health and the School of Medicine. Also wanted to share with you some news that we are going to be rolling out a new diversity, equity, and inclusion series in the fall of these virtual events that discusses the different UNC Health and School of Medicine pipeline initiatives. So be on the lookout again for that. And then next week, we've got our very next Game Changers, which is also going to focus on UNC Lineberger. It's going to be about a program that's really grown tremendously over the past 7 or 8 years when it was instituted. And that is our cellular immunotherapy program under the leadership of Dr. John Soroti. That program is having tremendous impact on a number of different cancers. So I know that you all will probably want to tune in for that one. That'll be on June 30th. There will be, I think, a registration link that was going to be posted in the chat to that, but we'll be sending the invitation out to this group and more I think next week for next week's event. So as you sign off, I do want to encourage you to fill out a survey. And you can use that survey to suggest future event topics. Be in touch with us about how you'd like to be engaged. And we really, really appreciate your time today. Thank you for joining us. And again, thank you, Dr. Brewster and Dr. Wheeler. That was a terrific program.
Well, thanks for the invitation and for everyone who helped set this up.
Yes, thank you. I'm glad to be here. And I just want to close with saying there's no better place to be doing this kind of work. I think it's in the mission, it's in the blood of UNC to really be focused on the state and really the people of the state. I'm proud to be here.
We're a fiercely public institution. All of us are proud of it, I know. So thanks.
Go Heels.
There you go. All right.